All right. Well, it looks like we have a good group of people coming on for the ultrasound case series this morning. So I will go ahead and get started here. So I have the pleasure of introducing Dr. Richard Chang. He's going to be our speaker today, and he's a fellowship-trained, board-certified physiatrist who specializes in non-operative sports and interventional spine medicine. He is a Brooklyn native and alumni of Brooklyn College's BA and MD and Macaulay's Honors College program. His physiatry residency was completed at the Icahn School of Medicine at Mount Sinai Hospital, where he also had the honor of serving as chief resident in his last year. His fellowship training was in interventional spine and sports medicine, was then completed at the Hospital for Special Surgery, and he currently serves in several roles as Associate Program Director of the Sports Fellowship Program at the Mount Sinai Medical Center in New York, and also enjoys volunteering his time with the Ultrasound Education and Health Policy Committees through AMSSM. And today he's going to be giving us an ultrasound case series presentation on an ATFL tear.
Thanks so much for that kind introduction, Dr. Schaff, and thanks to the Ultrasound Committee for allowing me the opportunity to present this case. So I'm going to share my screen. I think we can all see that.
Yep, that looks great.
Perfect. Thanks again. So, so I'm going to be presenting on specifically on a case on the anterior ligament tear. We'll talk a little bit about the case, and then we'll review sort of the standard ultrasound scanning protocol that should be done for the mainly for the lateral ankle. And then we'll review some relevant images to the case, and we'll discuss the final ultrasound report, and then hopefully some Q&A. So this is a case of a 19-year-old healthy sort of female collegiate foil fencer. This was one of the large summer tournaments that USA Fencing holds in the summer, usually about over a week. During the competition, during the bout, she was lunging at her opponent and noted when she landed on her foot, she inverted and rolled her foot inward. She didn't hear any sort of significant pop or sound, and she could bear weight afterwards and was able to finish the bout. But then noted afterwards, increasing sort of pain and then swelling, and then walked over to the sports medicine tent where I help volunteer as part of the medical team, and she was wondering if she can continue competing. This was early on in the event. Other details, no major medical history. She did, however, endorse another sort of similar inversion ankle injury during training or practice 3 months ago. Otherwise, no major orthopedic surgeries, no change in medications, no change to other training regimen or gear, weight or menses. What we saw in the sports medicine tent in the convention center, she was not in acute distress, but we did notice that she was her gait was antalgic. She was able to weight bear, but noticed increased pain with toe walking. In terms of sort of balance, she had sort of poor balance when standing on the right lower extremity. In terms of dynamic testing, she was able to do a standard sort of lunge with the sort of the knee, her dominant leg, knee flexed 90 degrees, and the back leg sort of extended. But with the fencing lunge, where they go more in knee flexion with the dominant leg, and in this case, it was her right leg, she noticed increased pain. When we took off the gear and then looked up so the skin, noticed that there was some visible swelling on the anterolateral part of the ankle, some small ecchymoses, not much redness. In terms of exam itself, there was tenderness to the right anterior talofibular ligament region, also more superiorly along the anterior tibiofibular ligament and along the anterior joint line. Some less tenderness though along the posterolateral ankle, along the calcaneofibular ligament, and sort of the other parts exam was to make sure she didn't have any significant acute bony injury along the metatarsal, cuboid, the midfoot, distal fibula, or immediately along the deltoid ligament. Range of motion pretty much full, except it was restricted with mainly, well, in most planes, it's primarily with dorsiflexion due to the swelling. However, when when we're reproducing sort of the mechanism of injury, she did notice increased pain. Otherwise, neurologically, is intact. Vascular is also intact. Strength was fine, but again, somewhat limited, decreased strength due to reproduction with that inversion and contraflexion. I'm sorry, inversion, eversion was low pain. In terms of special tests, there was positive right anterior drawer. There was increased sort of ankle inversion with talar tilt. However, with the squeeze test above the malleoli, that was negative for any tenderness. In terms, we're really worried about, like sort of ankle inversion injury, ligamentous and bony, but again, we should also consider other diagnoses. These are the films she actually got later, or I would say probably, during the time of the competition at urgent care. There is some swelling laterally along the fibula, but I don't see any sort of cortical irregularities or sort of evidence of acute bony injuries. So, the x-rays were essentially were negative for any acute bony processes. So in terms of differential diagnoses, I know there have been similar lectures and talks, done wonderfully by Dr. Hoffman and Dr. Iberfredi on the lateral ankle. But in terms of differential, again, one way to approach it is to, you can break it up by group, whether it's bony, ligamentous, tendinous. I do a similar approach, but obviously also I try to rule out the more dangerous pathology or things that you want to make sure the patient doesn't have, so that you don't have to refer them out to a more acute care setting like in the ER or a hospital. So, most likely it sounded like an acute lateral ankle sprain, given the mechanism injury. And, these are fencers with their dominant legs, they tend to, sprain often, especially during training. But like most, I would say, athletes, especially high level athletes, they tend to work through the injury. The other things that you want to look up more, make sure that they don't have as proximate as like a syndesmotic sprain. On her exam, she didn't quite have tenderness there, but she did have some little swelling or effusion there, possibly. Bony injuries, want to make sure it's not a cuboid fracture or a fifth metatarsal, basically fifth metatarsal. She didn't hear a pop, but again, you're worried maybe talar dome injury or injury to the or osteochondral injury to that area as well. Other things that we would also think about is any injury to the sinus tarsi or subtalar joint, which is less uncommon, but I think it's diagnosis to consider. And then besides that, you would also worry about injury to the peroneal tendons. So before we dive into my specific case, in terms of scanning protocol for the lateral ankle, majority would be looking at the ligaments, as we mentioned, the ATFL, the IATFL, and the CFL. Majority, I would say you can do a dynamic exam for all three. I would say mainly we do it for ATFL and CFL. AITFL you can do with a little dorsiflexion inversion. The peroneal tendons are what we also look at as well, and then the surrounding superficial peroneal retinaculum or fibular retinaculum. And then posteriorly, the strongest ligament, which is the least uncommon to be injured, is the posterior talofibular ligament or PTFL. That should be part of standard practice. Optional, given that it's not just bone, tendon, ligament, you should also make sure it's not neurovascular. So the sural nerve should be scanned. Bifurcate ligament injury, it's more obviously it's close to ATFL, maybe a little more anterior. I know Dr. Hoffman's talk went into this in awesome detail. I'm not going to quite go into this lecture, but that's something I think that should be considered. And then if you're looking at peroneal tendons besides peroneus longus and brevis, and if you're scanning down from proximal distal, there's some anatomical variations like the peroneal cortex that you should look out for. Or in terms of what I did for this specific case, pretty much similar to the lateral ankle sort of scanning guidelines. I added a little bit anterior given her presentation. given that she had some tenderness and swelling to the joint line. So I did include the intertibutalar joint. I do look a little bit at the distal fibula because you're worried about an avulsion injury, given that she had a prior ankle sprain, in addition to this current injury. And then again, we often emphasize this, but we, generally try, well, you do your best to always scan the contralateral limb, given that it's always helpful to have a comparison. And then with these sort of athletes, they may have overuse injuries or slightly altered anatomy. But it's always good to have a comparison. This is just an anatomy review. Majority, I would say, you're aware of this, but just a friendly reminder in terms of the the major ligaments with the ATFL, if you look at a clock, it's sort of like in the 2 o'clock, 2 or 3 o'clock position. If you aim toward the first or second metatarsal, the ATFL is more superior in the syndesmosis between the tibia and fibula, and the CFL is sort of more obliquely from the distal fibula to the calcaneus, and then the PTFL is sort of horizontal, following the base of the foot, from the fibula to the talus. And then the bottom, of course, is just sort of a netter depiction of the soft tissue structures, tendons, and bursa. On the right side, again, it's just time mechanism to stressing the specific, I would say, ligamentous injuries. So in terms of grading types, I would say there's different grading types for ligamentous injuries. Majority, I would say the most basic would be on the right-hand corner. The AMA, or the American Medical Association, actually has a grading system with grade 1, the least severe, and grade 3, the most severe disrupted. Grade 1 generally just be a sort of micro tear where it's not a visible injury. Grade 2 is involvement of the ATFL and the CFL, and there's at least a partial thickness injury, and then grade 3 is a sort of disruption of the whole ligament with laxity, with or without involvement of the posterior talofibular ligament. The other two, in the first two columns, O'Donoghue and the Leach sort of classifications, give a similar sort of approach to it. And this is something that we're going to bear in mind, and then we'll try to tie it with the ultrasound. So again, this is just a sort of refresher, in terms of just a basic scanning protocol. So, for the anterior ankle, we're looking at the tibio-talar joint. Here on the right-hand side of the screen, we have the tibia and the talar dome. This is her normal side. Essentially, there's no fusion, there's no cortical on the long axis. On the corresponding short axis, what you're looking for as well is looking at the deep parallel nerve and the associated nerve, vein and artery, as well as looking at the extensor retinaculum and any disruption of the soft tissue or tendon structures like the tibia acetans here, which is less commonly injured in these type of injuries. Going more laterally, again, the more high yield structure will be the intertalofibular ligament. In terms of positioning, generally I'll have the patient sitting with the knee flexed and the foot planted. If we have access to a towel, essentially we'll put a towel underneath the ankles to allow a little bit of that inversion moment and to allow some dynamic testing. If they're on a table, usually in these sport coverage events, then I might have them also just have the ankle off the edge of the table. In terms of positioning, you want your proximal end probe on the distal fibula, and again, there's sort of various ways to help increase visualization, but I would say the most common way is sort of horizontal if you're parallel to the feet or to the base of the feet, or I know some other authors recommend pointing towards the second metatarsal, since there's a little bit of oblique angle that you take trajectory to sort of see the hypercoic fibers of the ligament. This example is actually taken from Jacobson. The bottom one is actually the fencer's good her non-dominant leg, her back leg, so to speak. It does look a little thickened. I would say it's more the brightness of the picture that's taken, but there's no fusion, there's no cortical irregularity here. When we're looking at sort of dynamic testing, we're testing sort of with the inversion and with the ankle plantar flex. This is on the good side. Again, this is sort of more anisotropy. Again, you want to capture sort of the fibers from the distal fibula or lamellus to the talus. She does have maybe a little effusion. Again, it's not unreasonable given that she was just competing. So I'm gonna play the video. And again, when you sort of stress the ligament, again, generally what's cited in the literature is about 2, maybe at most 3 millimeters thickness, and that there's no significant gapping of the joint. Of note, she does have a little bit of a spurring here on the distal fibula, so most likely she sprained this ankle in the past as well. Moving, I would say if you move her probe from a horizontal sort of oblique position and then turn it back up, I guess toward the 1 o'clock position. Again, your proximal end of the probe is going to stay here on the distal fibula, and you rotate your distal into the tibia. And what you're looking for, again, is similar structure, sort of hyperechoic fibular pattern, sort of bridging between the two. And unfortunately don't have a dynamic video of this, but to stress the ligament here, you would dorsiflex and invert at least dorsal and invert the ankle to sort of stress the ligament here. And then here she has a nice ATFL on her contralateral side. Going sort of posterior around the other end of the clock, I would say to look at this calcaneal ligament and the perineal tendons. Sort of this is like 6 o'clock, sort of retromalleolar along the fibula. Essentially, you're looking for, again, a hyperechoic fibular pattern deep to the perineal tendons. And then it's actually lies, if you actually here, we scan a little bit more distally, you can see the posterior subtalar joint here between the talus and calcaneus here. Underneath, again, is her example of her CFL. I mean, there's a little bit of thickening of her perineal tendons, and their CFL is somewhat thickened, but is more or less hyperechoic, and I don't see any discontinuity or fusion. This is a dynamic exam video. Again, we're looking at the CFL. I'm sorry. This is a video that as we scan down from the perineal tendons from the retromalleolar groove down to the perineal tubercle. So we're just here. What we're looking for is in terms of perineal brevis longus, if there's any sort of snapping or subluxing, and again, if there's any sort of abdominal pain also listed on exam. Just want to make sure. I have video of the abnormal side for the CFL. Lastly, I would say for the posterior talofibular ligament, this is cited from a study by from a Polish group, more recently published. And again, I would say, but generally you would start from the distal fibula again on the proximal end, and distally you would place along the talus. Sort of horizontally. There are like other posterior ligaments on the posterior ankle, such as the posterior inferior tibiofibular ligament on position 1, or in position 2, the transverse tibiofibular ligament. But for the large PTFL, again, you want it in sort of this position. This is the screenshot of the what is captured in this article. Again, similar sort of hyperechoic fibular pattern. There's no disruption, and again, there's no underlying cortical irregularity. And then this is a snapshot of the fencer's normal side, crossing from talus to fibula right here. And then superficially, we perineus brevis muscle. So that brings us to my case. So anteriorly, I would say, partially because when we were scanning, I didn't have access to the machine and we're using portal ultrasound, but we were looking at the long axis view of the tibio-talar joint, again, looking from the tibia and talar dome. The superficial soft tissues look normal. I don't see discontinuity. I know it's a little hazy, but it's a portable, that's a portable ultrasound, sometimes a disadvantage of using that. But she does have some effusion deep to the joint. Short axis, there wasn't any abnormalities with the deep perineal nerve or the tibialis anterior or the essential hallucis longus. Getting to the meat of it, I would say for her anterior talofibular ligament, you can see, this again, this is fibula and this is talus. You can see it's thickened. There is a hypocoat defect in the mid-substance of the ligament, as well as I would say especially on the attachment site on the talus, and a little bit of sort of hypocoat defects also as well on the fibular end. Interesting enough, there was a what looks like an adhesive or most likely probably an older avulsion injury, given her prior ankle sprain in the past. This is a dynamic testing of the tear, just to appreciate more of the hypocoat defect, and you're trying to look for widening, not just of the joint, but also if there's any separation of the ligamentous fibers. Here, I mean, I didn't have a screenshot here, but when I turned on the color Doppler, there was some hyperemia. So again, indicating that it was acute process and inflamed. And in terms of measurements, I don't think there's any standard measurements in terms of gapping or widening of the ATFL that I see in the literature so far, but there's some sort of working to it, especially with this recent article that was published actually a couple years ago, but this is from a Japanese group, Komochi, and they were trying to create a standardized sort of protocol describing ATFL tears, mainly looking at besides the severity of injury, whether it's partial thickness, full thickness, and description of the ligament, looking at the location. So in their journal article, they published, they basically reported or wanted to sort of emphasize the need to report if there was injuries at the fibular origin, which is most commonly sort of injured, or at the mid substance, or at the talar end. For the AITFL, for this case, here you can see there's disruption of the ligamentous fibers bridging from the tibia to the fibula. There's a little bit of fusion deep to it. On dynamic exam with eversion, there was a little separation as well. Unfortunately, the video wasn't saved when I was using the portal ultrasound in this case. For the calcaneofibular ligament, luckily, I'll play the video, but it is thickened, but again, I would say that was a sign of like or just overuse. But there's no discontinuity. There's thickening of the perineal tendons, but there's no subluxation. The supersupranular retinaculum looks intact as well. But with dynamic testing with dorsiflexion, there's no sort of the ligament is nice and taut. And then going more posteriorly, again, at the posterior subtalar joint, there is no fusion deep to it. And then actually, when I scanned a little bit more distally at the fifth metatarsal, there was no bony irregularity, irregularity or tenderness there. And then this is just sort of scanning more distally at the perineal tendons. Again, usually with tendon acute injuries, or I like to turn on the color power Doppler just to see if there's any active hyperemia. There's a little bit of effusion here. Again, it's probably some sign of tendinopathy. I wouldn't quite call it tenosynovitis, I guess. I mean, because I'm going to show the long axis views. Long axis, again, there's thickening of the tendons, maybe a little hypogenicity. There's some fluid around it, but there isn't. I didn't notice any hyperemia, in the tendon sheath itself. So I didn't quite call this tenosynovitis. I just called it tendinopathy. And then just to round it about, just to make sure, even though she didn't have a significant pain, it was good to just make sure that she didn't have any neural injury. Her sensation was intact, but in terms of scanning protocol, this is a short axis view of the sural nerve, which can be found superior to the lateral malleolus. So this might be a little hard to see. This is the saphenous vein, and then the cranial nerve is right here, this honeycomb structure. And it's in terms of structures sandwiched in between is between the Achilles tendon and the peroneus brevis. And then last, I would say for her posterior fibular ligament, again, the nice fibular structure was present. There was no fusion, and with dynamic testing, there wasn't any sort of laxity noted. Again, this is somewhat a very uncommon structure to have injured, since it's the strongest of the three, and usually buttressed by these other two posterior ankle ligaments. So in terms of the complete report, sort of like the standard report that we generally have, you'll have, what we're just, what part of the body part you're looking at specifically. In this case, it's lateral as well as anterior, a little bit limited. The date, who was the referring provider or physician, who's performing the exam, the patient, and then a little bit of the history. I couldn't put everything into one slide, so I split up the findings and the impression. So findings, in this case, I would say for the scanning, generally you can use a high frequency linear array transducer, but in this case, I would say if you have access to say hockey stick transducer, I generally use that if I have access to that. In terms of what I described before, just summarizing, I said that there was evidence of tibial joint effusion, and usually I described going from sort of scanning from anterior lateral. And I'll mention in terms of the ligamentous structures, I described the ATFL as thickened, heterogeneous, with a full thickness helical defect seen within the mid substance, as well as in the talar attachment. Apologies, it's in the final impression, and that there's probably evidence of past bony avulsion given the that calcification are seen in the proximal and the distal fibula part. And with dynamic testing, there was winding of the ligament fibers and a little bit of the joint. However, in the AITFL, there was a partial thickness defect, but no laxity noted. The CFL, it appeared normal, and with dynamic testing, there was no laxity as well. And for the peroneal tendons, even though they looked thickened and a little hypogenic, there was no subluxation with dynamic testing. And for the posterior talofibular ligament, appeared normal. I didn't appreciate any fusion deeper to the posterior septular joint, and the sternal nerve appeared normal. This is sort of the full report, which I relate to the referring medical director at USA Fencing, and essentially, although the fencer was able to bear weight and lunge, unfortunately, she couldn't perform a fencing lunge, which is important. We withdrew her. She made the decision to withdraw from the tournament, and did an extensive course of physical therapy, and is doing well. These are my references, and thank you for your time.
All right. Well, thank you so much, Rich, for the presentation there. I'll kind of open it up to any comments or questions, but I can go ahead and start out with that. For these ATFL tears, this is definitely an area that I think ultrasound can for sure, shine. With the advent of the improvement in technology, especially with the resolution of a lot of these machines now, I think we've started to see that ultrasound is as sensitive as MRI. For taking a look at these isolated, ATFL tears. And obviously, two things that you kind of highlighted along with this is that you can always do a contralateral comparison, which is really helpful in a lot of these athletes, just depending on their dominant leg. And so you can easily get a kind of quick comparison to kind of see what is normal versus abnormal. The other advent of the ultrasound, as you had highlighted as well too, is the dynamic evaluation of this ligament. I think this is really important for any ligamentous injuries, just because sometimes these can be very subtle findings. And sometimes when you're looking at these statically, it can appear like the tendon fibers are still continuous, but as long as you then go ahead and do that dynamic evaluation, pretty clearly you can start to see, gapping and exactly where that gapping is located. Interestingly enough, more recently there was some studies taking a look at what is going to be the proper evaluation for looking at stress of the ATFL ligament. Obviously, a lot of the time we're taught that kind of anterior drawer test. But more recently, there was a study out of the group at UPMC, and they did a robotic testing to look at the stress of the ATFL. And what they ended up finding was that 30 degrees of plantar flexion with an inversion stress was going to be the best to evaluate for any type of ATFL ligament gapping. And so that's something that I've started to kind of incorporate as far as dynamic testing. Obviously, you can still do an anterior drawer, but when they look at kind of true stress on that ATFL ligament, that's what they found is the most helpful. As far as the protocol, I have very similar protocol to what you had detailed. Only thing that sometimes I'll kind of add in would be the sinus tarsi, especially if some of these athletes have more chronic injuries. Just taking a look at that area, especially for any type of tissue, abnormalities or just signs of an impingement in that region. For these ATFL injuries, especially them being ligamentous, sometimes they can be hard to detect. And so I always kind of view these as far as calling injuries, looking at both direct and indirect signs for these ligament injuries. And so some of the direct signs you had highlighted greatly here, which are going to be taking a look at just the overall thickness of that ligament. Obviously, if you're having a ligament tear, it's going to get thicker at that region. And then also just looking at, of course, the echogenicity of that ligament. So if there's any type of disruption, as well too, then tension of that ligament. So of course, with any type of ligament sprain, partial tear, or obviously complete tear, you're going to start to get more decreased tension and then laxity within that ligament. So those are all things that I initially kind of look at for direct signs. But then obviously there's going to be indirect signs that you can see with these as well too. One that you demonstrated is going to be any type of that periosteal avulsion. Those can occur, both from the fibula as well as then the talus. And then two other subtle findings that you even saw a little bit in the video that you demonstrated. Sometimes you can have this kind of inward, soft tissue herniation from above that will kind of dip down. And of course, that's just because of the laxity and loss of tensile strength in the ligament. You can also have the opposite where, deep to the ligament, you actually get some outward herniation of the capsule of the joint that's kind of coming up into where that ATFL ligament should be. And so those are just, some things that you can look at indirectly for these injuries as well, too. And sometimes those can start to cue you in, hey, maybe this is an area that I should start to interrogate a little bit more for a sprain if you are starting to see those. And then lastly, just kind of coming back to the protocol, you had mentioned it. Of course, you can start to look at some of the mid-tarsal ligaments as well too. Obviously, I would just cue into those more if patients are obviously having more clinical signs over that area. Sometimes it can be important taking a look at those, not really from a specific treatment standpoint, but I think more for like prognosis and kind of return to play. That obviously, if those ligaments are injured concurrently, they can just have a more prolonged course returning to play for those athletes. And so those are just kind of some of the comments I'll start out with. We do have one question here, which is a good one. This is coming from Jennifer that had mentioned, is there an optimal time frame on performing a diagnostic ultrasound to evaluate ligament involvement of acute ankle injury similar to muscular injuries to avoid any false negatives? Rich, do you have any thoughts about that?
Oh, that's a great question. Hmm. I mean, I did this exam essentially sort of on the sideline and within that same week. But I mean, I think the couple studies I reviewed on the literature, they said within a week or two. I guess if you want to, I don't know, false positive meaning if you're worried about like like infusion or like other findings or distracting or not having be able to visualize the structures of interest. I don't know if that's what Jennifer was sort of alluding to, but um, I would say
I
with
think, yeah, I think One thing, obviously, with the more often than not, is like with the hamstring and calf strains. Obviously, they say probably within not within about 48 to 72 hours, is because you can get a false negative before some of those pathological findings occur, within the muscle, especially hematoma formation. Interestingly, I don't think it's really been looked at greatly for ligamentous, injuries. But I would say, probably typical kind of time frame. But even for ligaments, I would imagine you'd probably still be able to see those kind of acute complete tears fairly early on. I think the hardest thing though is obviously with a lot of these early on injuries is you're going to have so much edema, in that area that sometimes it may make it a little bit more difficult to detect. Um, these injuries, and so ones that obviously you can continue to follow, especially as soon as you get out of that kind of more acute time frame within that 48 to 72 hours, to just kind of get some of that subcutaneous edema to kind of calm down, so you can evaluate these injuries in greater detail. But yeah, I don't think there's a lot of evidence out there to suggest when is the optimal timing for these.
Yeah, hi, this is Doug Hoffman. I would agree. I do think there is utility for ultrasound in the acute setting, and it really shouldn't greatly change the view of the ligament, from acutely to 48 or 72 hours, as you mentioned, Stephen.
Yeah, yeah.
And you can also look for avulsion fractures, especially if you don't have radiographs available on the sidelines. You can also look for a distal fibular fracture, um, or other acute fractures. So I do think there is utility. Um, I had a couple comments to piggyback on Stevens. Just protocol comments. I just want to underscore um, the sinus tarsi. So that's part of my lateral protocol. And
Mm,
specifically, the reason why I do that is you get a really nice look at the anterior process of the calcaneus. And so you can have anterior process fractures. So it's a nice screening tool for anterior process fractures that can be missed on radiographs, as well as a potential bifurcate ligament injury with or without bony changes. So that's part of my protocol. You had shown the subtalar joint, the lateral subtalar joint. That's also part of my protocol. And through the years, I always reevaluate whether I should be looking at certain structures, what's the yield, and subtalar kind of makes the grade, because if I see an effusion in the subtalar joint and a lateral ankle injury, then there's probably going to be a subtalar injury, whether it's just a bone bruise or an actual fracture. And it's going to make me think about an MRI if I see an effusion in the subtalar joint. When I do the anterior tibial talar joint, if I do see an effusion, and I suspect that even with fairly low grade lateral ankle sprains, there's probably a little bit of fluid. But if I see a significant effusion, then what I'm going to do is plantar flex the talocrural joint, and as far as I can, or they will allow me, and look at the lateral talar dome. And so you can see into the mid talar dome with plantar flexion. And so if they have a joint effusion, then that would be another view that I add to my protocol.
mm,
And then finally, when I do the anterior talocrural joint, I just slide in long axis, I just slide the probe down and look at the dorsal talonavicular joint, because that ligament can be torn often. I'm not sure it's going to really change treatment. I don't think we've really explored that, but we do see a lot of small chronic avulsions when we get x-rays of athletes, of the dorsal lip of the navicular. So that's just another view I get. In the sinus tarsi too, I mean, if you're adventurous and with a little practice, you can also see the cervical ligament, but that would be a significant injury. I think what I'm going to just highlight exactly what Steven says is I actually had the opportunity to meet the Japanese author of that view that Stephen mentioned, the 30 degrees of plantar flexion and internal rotation, 3 or 4 years ago. And he had mentioned his findings, even before they started writing up the paper. So now I have about 3 or 4 years of just um, some some practice with that. And I would say I really like that view. I really like that view because one person can do it. You can consistently do it the same way every time. But again, to underscore Rich, both yours and Stephen's comment, the findings are qualitative. There's really, I mean, actually, there's been some numbers thrown out there, but those numbers are from cadavers. So this biomechanical lab in Pittsburgh, these are all done on cadavers. And so, but I think it's a start, and I like that view quite a bit. I think the last comment I'm going to make is when you slide the probe up after the ATFL, dorsiflex the ankle, and then look at the AITFL. When it comes to ultrasound, that's a game changer because oftentimes people with lateral ankle sprains will have tenderness in the syndesmosis. And so the question becomes, is there a syndesmotic injury along with this ankle sprain, which may influence treatment? You may decide at that point to immobilize someone if you think they have a syndesmotic injury versus early movement. And so simply you can just slide that probe up and look at the AITFL and know right away whether you're dealing with a syndesmotic injury or not. And that's really, at least from my point of view, has been a game changer because, now you can just manage this very concisely, either early motion or decide, wow, there's a syndesmotic injury here, and I need to think about potentially an immobilization. So those are just a couple of comments on, particularly with the protocol. But nice presentation, Rich. Well done.
Thank you. No, I appreciate all the feedback. And no, I mean, the fencer did get an eventual MRI, and it did confirm the ligamentous injuries. They didn't mention anything about the avulsion injury, though. Interesting.
Sure.
But yes, actually, in the article I cited earlier, in the retrospective that Japanese with the authors, they did mention after ATFL and CFL, they did mention the dorsotalonavicular and to a lesser extent, bifurcating ligaments were the next injured out of their 103 cases.
Sure, sure.
Cool.
All right. Well, thank you for those additional comments, Doug. Unless there's anything else, that will kind of conclude today's case presentation. So once again, we'll go ahead and meet in 2 weeks again, and that case is going to be going over a patellar dislocation. So thanks again for everyone joining in today.
Thank you so much, everyone. Have a nice weekend. Catch you later.